Aloha, everybody in Hawaii. It is really an honor to be here. I am going to talk about a shift in how we look at survivorship from mortality to vitality, because over the last 2 days, we've been talking a lot about how long someone survives, how long they go without progression of disease. So now I want to switch it to talking about the vitality of our patients. I'm a board-certified general surgeon who specializes in diseases of the breast, so I guess this is the surgeon hour, but I do not have nearly as cool as shoes as he did. I don't know if you guys caught them, but they were awesome. I am also board-certified in integrative medicine and psychedelic therapy, which you may say, okay, what is wrong with this woman? What is she doing? I have no relevant disclosures, but the one disclosure I want to make is that 44 years ago, I left Pennsylvania. You're going to go, why is this Howley chick here talking to us as a surgeon about survivorship? Because she's not even an oncologist. I came to University of Hawaii 44 years ago to spend my sophomore year of college because my older brother, who was 27, had been killed by a drunk driver, and I was broken, and I didn't know which end was up. And I had always thought about Hawaii as being this great place to go after I graduated from college, so I decided to go before I graduated. Spent an amazing year here. I had 4 credits of hula, did pretty well. And I learned about ho'oponopono, which allows you to heal and let go of things that otherwise will eat you up inside. And I think that that has really stuck with me over the years. So to be back here 44 years later on this stage speaking to colleagues that specialize in oncology is really a great gift. And so for that, I'm very, very grateful. July 3rd, this came out, Cancer Survivorship in the United States, Commission on Cancer. Everybody's talking about survivorship. They're talking about fertility and sexual health, things that may not always happen in a regular conversation when someone first comes to you with cancer. As a breast cancer surgeon, it's top of mind for me because the last thing that I want to do is create a fertility issue in my young patients, because I want them to know that I think about their fertility at diagnosis so that they can think about, oh my God, if she's talking about babies, it means I'm going to live. By 2032, we're going to have 23 million cancer survivors in the United States. And these are people that have already gone through all the treatments that we've given them, so I think we really need to put survivorship at the center stage. I'm going to talk about the guidelines. I'm going to talk about the recent updates from ASCO, which to me were kind of paltry compared to what we really need to be doing with our patients, but I'm going to change that in the future. The basics of nutrition and exercise, how to mitigate side effects. I'll give you some do-it-nows and take-homes. So that drug that was causing arthralgias that were really bad, I got something that can help your patients. And then we're going to talk about stress management and releasing fear. And to me, the most important thing is we've got to promote mental wellness, because your patients will not exercise, they will not eat, and they will not sleep well at night if they are mentally depressed, anxious, or living in an existential crisis. So let's prevent the consequences of treatment, because it's going to keep our patients more compliant. We obviously want to promote a decrease in recurrence, and we've got to focus on the psychosocial emotional needs. So this is the way I have seen the last 35 years of my practice, going from how do I keep someone free of disease and how do I maintain their quality of life, because it is a constant balancing act. None of us get this easily. How do we balance the quality of our life compared to the quantity of our life? And if I ask my patients, would you rather live a long life miserable or a short life happy? It's the moments in life that take our breath away that matter, not the number of moments in life that we get to breathe. And we sometimes forget that, because as we look at data and statistics, it's where the focus is. So I pulled up everything that I can find, and everybody's got it. Survivorship guidelines, NCCN, for breast care, for the NAPBC. It's all there. We all have standards about what survivorship is supposed to look like. And the first paper that I published on survivorship came from the ASBS in 2016. And it was kind of like we were just kind of putting it out there for our colleagues to begin to understand the importance of survivorship. And this most recent standard said survivorship has to begin at the time of diagnosis. If we're not thinking about this from day one, we're going to miss the opportunity to help our patients go forward and live a very full and happy life. So on COC, what I found when you look at the COC survivorship guidelines and you really dig into it, you can look at the whole list, the laundry list of what we're supposed to do. But the only things that are required to get accreditation or to have a survivorship coordinator and to have a survivorship care team. It doesn't mandate having a medical oncologist on there, which I think is criminal, because if medical oncologists are the ones prescribing the medications for our patients, they should be involved in that survivorship piece. And you're not even required to deliver a piece of paper. And I used to say, you know, it's when I did our first NAPBC survey, they didn't ask about how we followed the metrics of the pieces of paper we handed our patients. They just wanted to see that we had a piece of paper. And to me, we had a good grade on our report card, but we didn't do really well in practice. So this year at ASCO, yoga and cognitive behavioral therapy on insomnia and fatigue. So they looked at yoga, placebo, and cognitive behavioral therapy. And what they found was that people that did yoga and cognitive behavioral therapy had less cancer-related fatigue. What's important is when you realize this is a combination for insomnia and fatigue, if you're not sleeping well, you're going to be fatigued every day. So sleep is where our bodies rest and digest. It's where we recover and function better every day. The Alloactive trial looked at exercise and sedentary behavior and cardiovascular dysfunction. These are for people going through transplant. Aerobic training and strength training, every one of us should be doing it, not just our patients going through chemotherapy or stem cell therapy. And reducing sedentary time and increasing activity led to better cardiovascular outcomes. You know, they say long-term studies are needed, but we've already seen a benefit. So I would say keep it going, and I wouldn't want to be randomized to the group that didn't get it. The MENAC trial, which multimodality exercise, nutrition, anti-inflammatories, and cachexia, this is for people that have really potential great loss of their body mass when they're going through treatment with pancreatic and non-small cell lung cancer. So they used Motrin as an anti-inflammatory, they used nutrition, exercise, and psycho-emotional education. And what they found was by having this multimodality approach and making it a priority, the patients did better and stopped with the weight loss that they would normally have during our treatments, which they need the treatments so that they can have a longer life. So here's the deal. We are what we eat. Luckily, we've had great healthy choices here, I have to say. Everybody should agree on that. I mean, the food is phenomenal. That purple yogurt, that stuff is deadly. I want to take that back to the mainland with me. The problem with nutrition is every single month the headlines are confusing. Low fat, no carbs, high carbs, no carbs, go into ketosis, and it is absolutely maddening as our patients will come to the office with a new headline going, okay, doctor, here's the diet of the month. So what do? So lifestyle on breast cancer has been studied probably more than with any other cancer. And I do think the standard American diet is really sad. And you know, it's unfortunate that that's the acronym for it. But we know that with low sedentary, low physical activity and poor dietary choices, we're going to see an increase in breast cancer for a lot of different reasons. But it's pathetic because we don't really talk to patients. I hate going into an oncology center and seeing freaking, you know, donuts and cookies sitting on the countertop as the only choice for my patients to eat. Yes, it sucks to go through chemo, and yes, you want to eat things, you've got to have calories, but my God, we can have better choices at the outset. So we get to choose between a pro-inflammatory diet or an anti-inflammatory diet. And we can either feed the disease or we can starve the disease. It's a choice. And this isn't just for our patients. This is for us as living human beings that I don't want to get cancer. I don't know about you guys in this room, but I do not want to be on the opposite side of any single one of you unless we're sitting down to dinner, you know, having a conversation. So what we did at our institution, my hospital in Pennsylvania is part of MD Anderson, and we decided what happens if we refer patients for nutritional counseling and just refer them. So we referred 100 patients. They all got the appointment to go. Only 50 of the 109 scheduled it. Out of that, 32 showed up at the first appointment, and 29 came to the last. So we had, you know, 25% of our patients actually went for the consult. What was good is we had an average of 10-pound weight loss when they got really good education about what to eat and what not to eat. So we're taking it one step further, and hopefully next year I'll be here talking to you about our results. Because now we're going to say, what happens if we really get on these people's backs and we text them and we email them and we make their follow-up appointments and we actually follow this as a prospective trial so that we can track outcomes. So I'll be back to let you know next year if we can get higher than 20%. To me, if we get it to 50 to 75%, I'm going to call that a win. because those are patients who are getting a positive impact from a very easy intervention. Intermittent fasting is another opportunity for our patients to be able to impact their risk of recurrence. The fasting has to be greater than 14 hours a night. I tried it, it actually works. I tried it before I got my patients to start doing it, because I always thought, I'm a surgeon, I deserve to eat breakfast before I go to the operating room. I don't want to pass out, am I going to get lightheaded? But it's easy to fast, it's not a hard thing. And intermittent fasting, if you look at all the blue zones in the world where people are going to live into their hundreds, it's a big part of how it all works. So this is not, at least I didn't have to do this talk last night right before happy hour. What constitutes one drink? Because my patients say, oh, doctor, I only have 2 or 3 drinks a week. And I say, well, how big is your drink? 5 ounces of wine or 1.5 ounces of a distilled spirit is 1 drink. And that's really what my breast cancer patients should be drinking at max, probably 5 days a week. Unfortunately, this is what I see. You go to the bar, and you got the big glasses, and you got the big pours, so it's all relative. So if you say to your patient, how big is your 1 drink a day? And ask him to actually measure it out, because I bet you, you go to a bar, you're gonna get a 4 to 6 ounce pour of wine, and you're gonna pay a fortune for it. You go to your friend's house, you get a 9 ounce pour, and you are not having the same equivalent. So exercise oncology has become one of my favorite topics. Jay Harness, who was the past president of the American Society of Breast Surgeons, when I gave my first talk at the ASBS, and I was far out on that limb of integrative medicine in 2004, he said, I think you might have something to what you're doing. Because he was president way back then of the society, not the United States, because nobody wants that job. Jay has now, in retirement, taken on the role of being the educator to all of us about exercise oncology. He sent me this paper recently looking at the metabolic equivalence and distance recurrence-free interval in this CANTO trial, which was a prospective study looking at activity. It wasn't just how many days a week do you go to the gym and exercise. It's how is your lifestyle? How sedentary is your lifestyle? Are you moving and grooving? So what I found was really interesting. There were 2 groups that had a statistically significant result with more than 5 MET hours per week: premenopausal women and HER2-negative women. And the HER2-negative women the ER-negative, HER2-negative women had the biggest difference in the curves. So they had the biggest benefit from exercise. And that was counterintuitive to what I've always been thinking about, that belly fat is precursors for testosterone, precursors for estrogen, so it should be the ER-positive patients that get the biggest benefit. What was really interesting is the postmenopausal women did not see a difference in their curve until out to 8 to 9 years. And I think a lot of this is because these postmenopausal women are much more compliant on their aromatase inhibitors, because my premenopausal patients freaking hate tamoxifen, and many of them lie about taking it, or they don't take it, and some of them may not even be converting it. But there's got to be another reason why this study showed what it did with exercise. And I'm going to combine it now with another study, which this came out in April of 2023. Looking at exercise as an independent factor based on the time and intensity. So what they showed was there's a mobilization of leukocytes, CD8 T cells, and natural killer cells. And what it showed was there was an absolute dose response. The more you exercise, the higher the levels of your natural immune surveillance. So imagine that HER2-negative, ER-negative group getting the biggest benefit, because they're now turning on their systems to go after those cells themselves, where the women that are on anti-estrogen therapy, they already have a level of protection from their tamoxifen and their aromatase inhibitor. But it makes me know that I'm going to continue to do this. I live in Sedona. And no, this is staged. My son put me up there. I don't rock climb. I was hiking, and he said, Mom, I can get a really cool shot if you pretend that you're climbing the side of the mountain. But exercise is exercise. It doesn't have to be going to the gym. You can be hiking, you can be walking, you can be swimming. You got to move it. You got to move. So there was another systematic review looking at exercise and what it does for anxiety and depression and distress. Lo and behold, cancer is a chronic disease. I always tell my patients with metastatic disease, I want you to have a really long case of NED. And they're like, what's NED? I go, no evidence of disease. So I want you all to get NED, and the way to get NED is to work really hard, take your prescribed therapies, and let us help mitigate the side effects. Exercise has a boost. You can't tell me you don't get an endorphin high when you guys exercise. It is a wonderful thing. You may not want to go to the gym right away, but when you get your butt out of the seat, into the gym, you come out of it like, yeah, I'm buff. I got this. I'm getting in shape. Cancer-related fatigue, a really big deal. Just feeling drained and feeling, oh my God, I don't want to get up tomorrow. Patients that exercise always do better. They have less fatigue, probably because they're sleeping better as well because they've been exercising. But exercise, mindfulness-based programs, Qigong, and ginseng during treatment have been shown to be effective, as well as yoga and acupressure. To me, these are all there's no risk to this. There's absolutely no risk to any of these interventions. And we know in prospective randomized trials, 113 of randomized trials show it absolutely across the board that it works. So here's the deal. I have been a fan of American ginseng in my radiation patients since 2013 when the first paper came out, where my radiation oncologist, Bob Cardinale, at Tumor Board stands up and says, hey, Beth, you've been beating this drum for a long time. And now this study shows that American ginseng, which is specifically American ginseng, not any other kind because you don't want the estrogenic effect, it absolutely statistically showed an improvement in cancer-related fatigue. There are studies showing it as well with chemotherapy. Do not give it in patients that are on Coumadin, which is why the warning sign is flashing right there. Next warning, acetyl L-carnitine got a lot of press for its cardio benefits and for fatigue reduction, but during taxane therapy, it will worsen peripheral neuropathy. Do not give it in patients getting taxane therapy. So that is note to self. None during that, because peripheral neuropathy is the gift that keeps on giving. My friend from high school told me yesterday his wife tripped because she had chemo 20 years ago. She still can't feel her toes. She drug her foot, tripped and fell. And so if we can prevent peripheral neuropathy, like I love the fact that we have these Paxman cold caps and no dissing Paxman here. Hair grows back. Peripheral neuropathy doesn't get better. I would rather see my patients hooked up to their booties and their mittens during chemotherapy than on their head, because the peripheral neuropathy is something that will potentially negatively impact them for the rest of their lives. So I get my patients to buy these little mittens and socks. It's $50 a set on Amazon. Have them take them in the freezer, bring them to therapy, and statistically significant results in using it for cooling. Turkey tail mushrooms. I don't know, you guys saw I'm certified in psychedelic therapy. Turkey tail are not psychoactive, okay? But they do have, they have had an effect in a dose-related response with CD8, again, T cells, CD19 B cells, and they increase the natural killer cell function. They are no harm. They don't interfere with any other therapies. And I have my patients take them with their therapies, with their chemotherapy. But I do tell you all, if you are my oncologist, they're going to take them. All right, so this is your take home today. If you don't take away anything from this talk, from this little Hallie chick from the East Coast, I learned about this through studying homeopathic oncology interventions. Ristoxodendron and rutagraveolins, which you'll be able to say them. You guys can say all those immunimalibalab things. You're going to be able to figure out how to say this to your patients. That's why I couldn't become an oncologist. I cannot pronounce your drugs, for the love of God. Arthralgias related to arthritis are very, very well treated with ristoxodendron and rutagraveolins. And they did studies on this in patients going on aromatase inhibitors and tamoxifen. So I'm going to give you my cocktail here. When I start my patients on AIs, which during COVID, I had a lot of patients that weren't even getting in to see medical oncology because we were so swamped, and anyone with an ER-positive tumor, we were delaying them until we knew we weren't going to kill them in the hospital. So I'd start them on the ristoxodendron, the rutagraveolins, 5 pellets in the morning, 5 in the evening. I start their aromatase inhibitor, 1 pill every 3 days, the next pill, 1 pill every other day, the third week, 1 pill a day. And I have not done a clinical trial on it, but I will tell you that the patients are not getting the same level of arthralgias, and most of them are able to go off of the homeopathic support within about a month after going on it. It is inexpensive. It works for arthritis. So that drug that was on earlier that was creating all those arthralgias, like, don't throw the baby out with the bathwater. If there's a side effect that we can make better, let's give it a try. So Go for it. Reishi mushrooms, one of my other favorite mushrooms, suppresses the secretion of urokinase plasminogen activator. It also helps with anxiety and cancer-related fatigue, and that we believe it's anti-inflammatory. You combine the reishi with green tea with the ECGC, and you get a very potent synergistic effect, clinically studied in the International Journal of Oncology. These are very effective, inexpensive, basically supplements to care. So when my patients have triple-negative breast cancer and they come back after they're done treatment, they go, Dr. Dupree, you know, the other ladies in the support group, they're on tamoxifen and Arimidex. What are you going to give me? I said, well, you're going to have turkey tail mushrooms. You're going to have green tea and reishi mushrooms. You're going to exercise your butt off. You're going to increase your lean muscle mass, decrease your body fat, and have a nice day, because that's what I got. So the ultimate survivorship. And as a surgeon, I've always been asked by every med device company I have ever worked for, Dr. Dupree, what is the problem that we need to solve? And I said, well, you got to give me a device that cuts out fear when I cut out cancer, because that is the thing that is pervasive and continues in a patient's life from the day of diagnosis until they die of something else if we don't intervene. So is it possible to do it? And how do we begin? 17,500,000 cancer survivors in 2022, 23 million coming up by 2032. And it's mostly the fear of recurrence. It's the fear of death. We're all going to die. Listen, let's face facts. Like, if any of you get out of this alive, send me an email. Let me know. Let me know how you did it, because I want to know. And when our patients have this fear, it is not simply depression. It is an existential crisis. I am absolutely furious when a patient comes to me, gets diagnosed, sees their primary doctor, and when they come back in, my MA is adding Zoloft, Ambien, and Xanax to their list of drugs, and I'm like, for the love of God, you're allowed to be depressed, you're allowed to be anxious. I just told you have cancer. You're scared. So why do we constantly polymedicate these patients? So cancer brings up this whole thing. What is your purpose in life? I know what my purpose in life, and now it wasn't to be a really good breast cancer surgeon. It is to get survivorship on the map and get us to recognize the importance of how we do what we do and how it affects our patients down the line. You can break thinking patterns. It makes you think differently about everything in the world. And it also makes you think about your own mortality. You know, I'm not afraid of dying. You know, at one point in my life, I probably was. I had a really tough time when my brother was killed at the age of 27, trying to figure out how that all happened. But you know what? We all have to find our life's purpose. And sometimes cancer can be that impetus, that crisis that brings about that awakening in someone to say, you know what? I really didn't want to be a pharmaceutical sales rep. I'd rather be a firefighter. I'd rather be a whatever. And so, not that I'm dissing you if you're a pharmaceutical rep, just saying. One of the greatest gifts that I got is from my patient, Allison, who was diagnosed with breast cancer probably 10 years before I met her. She had a recurrence. She developed a lesion on her back, and she was kind of like delayed in her diagnosis and finding it. And when I finally met her and I had a conversation with her, I literally excised a 3-centimeter thing off her back. It was not a big surgery. But she said, you're the first doctor that ever really talked to me and connected with me and asked me questions about who I am and what I do and what fears I have. But she taught me about adverse childhood events. She had a horrible event as a child with a benign tumor of her thigh, of her femur. And she gave me this insight that through also my psychedelic training, I realized we should be asking our patients when they come in about their adverse childhood events, because this is the baggage that gets unpacked when patients come to your office and they're diagnosed with cancer, and we don't ask them about their baggage. We think they're going to tuck it all back in their suitcase, you know, but it costs a lot of money to take all that extra baggage on the plane. And there's no blood test for trauma. It's not like you can draw a blood test and say, what is your adverse childhood event score? So this is it's a survey that's 13 questions. It's psychological, physical, and sexual abuse. Huge incidence of PTSD in our patients, and a score of more than 4 has a 200% increased incidence of developing cancer. So if you don't believe that our bodies keep score and that this stress that we have in our lives isn't related to cancer, 450% increase in depression, 1,200% increase of suicidality, And people who have a score of 6 or over 6, they live 20 years younger than somebody else in an exact same cohort of their age and otherwise medical status. So PTSD is something that I believe that we desperately undertreat. About 80% of women have it after breast cancer. You know, it's the scanxiety, it's the anxiety of going back into a building where they had previous chemotherapy. And if only I had a tool to cut out that fear. So brings me into the next part of my life. Why did I get trained in psychedelic therapy? I am not a druggie. I grew up during that time when they showed the 2 eggs in the frying pan and said, this is your brain on drugs. My dad was a cop. No drinking, no drugs, no anything. And so when my friends who know me really well go, I can't believe you went and got trained in psychedelic therapy. And I said, well, guess what, kids? There is a lot of science in this phase, and I can guarantee you 10 years from now, God willing, I'm still alive, I'll be standing here at this conference presenting data on how we are all going to be using this as a potential intervention to deal with the baggage that our patients come into cancer with. So what got me really interested in this is antidepressants do not work in cancer patients. You may find that out. Your patients, only 38 to 40% get a response. That is the same as placebo, note to self. So there was a study that was done by Stephen Ross. He's a psychiatrist at NYU, looking at the classic psychedelics to treat cancer. He reviewed all of these studies. Most of these were done with LSD, which is not an evil drug. I know everybody thinks it is, but I've never done it, so I don't know. But I've been told by people that have done it how well it can help with psychiatric disorders. But there was this war on drugs because nobody wanted to go fight in Vietnam if they had an existential awakening and recognized that we have a collective consciousness. And right about now, I want to go to Washington and lock down Congress and dose all these people up on a little bit of psilocybin and tell them to get over their differences because what's happening is BS. I know you all agree. It's been a shit month of listening to everything. So he looked at 10 trials with 455 patients with advanced or terminal cancer, because when you're terminal with cancer, they'll say, okay, we're going to try this on you because your cancer is going to kill you anyway, so we might as well try it. So what did they find? 6 open label trials, mostly with LSD, 4 randomized controlled trials, rapid, robust, sustained improvements in cancer-related psychological and existential distress. Don't you think our patients deserve the ability to get past that fear and move on and really live a high quality of life? So this is the study that really did it for me. Roland Griffiths and Bill Richards. Bill Richards lost his wife to breast cancer when his sons were 11 and 13. He's the guy that interviewed me when I applied to CIIS. And I told him, I said, Bill, I said, I am a psychedelic virgin. I'm not one of those people that's been out at raves and dropping acid. I said, I am like this very conservative, howly chick from the East Coast, but I love your data, I love your science. Single dose psilocybin for patients with stage 3 and 4 cancer. 6 months later, still had a reduction in anxiety and depression of 78% and 83% respectively. Nobody gets those results with the drugs we have. And again, pharma reps, I'm not dissing you, but you guys sell chemo here. You're not here selling all the psychiatric drugs. So Manish Agarwal did this study out of the same institution. Single dose psilocybin led to remission of depression in 50% of cancer patients with depressive disorder. That is a big deal. We don't get those numbers with regular antidepressants. So this is a study that the results are pending. They looked at group interaction with psilocybin, which I think is going to be the way to go, particularly with my breast cancer patients, because there's already a bonus to the group effect when you get patients together. So this is a pilot project that used 1 psilocybin session. It's important to understand this is set and setting. I am not advocating for the illegal use of psilocybin, MDMA, ayahuasca, or anything, but in the appropriate set and setting, I will tell you it is life-changing. So this clinical trial is currently ongoing. So if you have patients here in Hawaii, if they have the ability to get there, they can go to NYU with Dr. Ross, because he's treating stage 3 and 4 cancer patients, single dose psilocybin, and believe me, the group that doesn't get it, the people that get the niacin, they have to know right away. That's one of the reasons it's so hard to do clinical trials, prospective randomized placebo-controlled because there's no placebo that lets you see God or meet God. So it's kind of like, you know when you get the real thing. So this trial opened in 2022, and it's expected to be completed in 2027. And full disclosure, this is a organization that just started in California. It's called the Survivorship Collective, started by a female breast cancer survivor who's a filmmaker. And I'm going to be part of the support team for this group of 10 women that are going to go. We haven't opened it up yet, so if you have patients, you know, it'll be on my LinkedIn page when we actually open up the trial. But we're going to take 10 women to Nereca, which is a facility in Mexico City, outside of Mexico City, for a 6-day retreat, 2 psilocybin sessions, and we are getting it IRB approved because, to me, if I can't publish this data so that you can look at it and bring it back to your institutions, it does us no good because it's all a one-off. Right now, the things that you can do, ketamine has been amazing for depression in cancer care. IV ketamine therapy is phenomenal. More importantly, for any of you that have patients with metastatic disease, ketamine is an NMDA receptor agonist. So your patients that have pain can be given low-dose IV ketamine therapy, get on lower doses of morphine, be more present with their families when they're transitioning. And to me, this is another thing that I want to see become part of standard care, because how we allow our loved ones and our patients to transition should really matter, because it's that end of life that can bring such anxiety into families. And for me, that's what this is all about. We're all on this journey together. All right, I'm going to finish with my vagus nerve stuff. So your vagus nerve is very important. For many of you, if you go through a stop sign and the cop pulls you over, you know that you are in fight or flight. Your cortisol has just hit the roof, and you are about ready to jump out of your skin because you think, oh my God, can I come up with a really good story about why I blew through this light? Like, do I pull the doctor card? Anyway, Stephen Porges has this polyvagal theory that looks at the 3 episodes of social engagement, fight or flight, or freeze and shut down. And what we can measure through heart rate variability is where we move through this entire continuum all the time, and how we can use this to move into a place where we can actually help our patients. And it's by increasing their resilience. So why am I going to study breast cancer patients? Well, I'm a breast cancer surgeon. I have access. That's why. It's easy. They come to my office. I don't have to go out and search for them. It's the most common major neoplasm in women in North America that cause death. The psychosocial impact, and what we're trying to do is normalize well-being. We're trying to give our patients the ability to feel good after a diagnosis of cancer. So it's going to be an open-label trial stimulating the auricular nerve, the auricular branch of the vagus nerve, and acupuncture points on the earlobes. It's going to be 5 50-minute sessions, consecutive days, and we're going to follow up at 2 weeks, 4 weeks, and after the last treatment. And this is called transcutaneous vagus nerve stimulation. Currently, there is one FDA-approved device like this, but it's used for neonatal abstinence syndrome, to get babies out of the NICU earlier, because when babies are born addicted, they're in fight or flight. They're addicted. They're like jumping out of their skin, so to speak. And we know that with utilization of vagus nerve stimulation, those children can come off of the addiction curve much quicker. So what we're trying to do with this is proved enhanced well-being. And we're going to look at the personal well-being score, the WHO-5. We're going to use the NCCN distress thermometer, because we all have it. I don't know how many of you look at it really carefully. Everybody has it in their chart, but I'd be willing to bet you that at the end of your visit, you may not know what your patient's distress score is. You just know that it's filed in the chart. And we're going to do an objective measure of heart rate variability. And since you might not know what heart rate variability is, I'll give you a short lesson. Heart rate variability is how we measure intra-beat variability. A lot of high-performance athletes measure HRV. A lot of people have little Oura rings and little bands and things, but what it's doing is it's looking at the difference between your high-frequency parasympathetic, your low-frequency sympathetic, and your very low-frequency CNS, which is like kind of the backup. And nothing speaks louder to me than a visual. So parasympathetic, rest and digest, it's the brake pedal. That is really good parasympathetic tone. Sympathetic, you're on the gas pedal. You literally have the pedal to the metal. You're not stopping. You're going, going, going. You're in fight or flight, and you can't even control the level that you're at. And that is when your cortisol goes very, very high. Then we have our backup system, which is very low frequency. It's the emergency brake. But the emergency brake isn't a good place to get, because that is a place where you're like, you screech to a halt. So somehow, we want to be able to get to a space where we have balance, where we get balance between our sympathetic and our parasympathetic and our overdrive. If we don't have sympathetic tone, you can't run from the saber-toothed tiger. But if you have too much sympathetic tone, you're never going to be able to rest and digest. So in summary, survivorship has to begin at diagnosis. We've got to think about the side effects. We have to think about the number of things that we do with our patients to help them live a better life, and continue to increase that list. We've got to look at treatments for anxiety and depression that do not include standard pharmacologic therapy, breath work, yoga, Tai Chi, anything that helps to stimulate the vagus nerve. If your patients sing or hum, that stimulates your vagus nerve. And with exercise, we got to move it or lose it. Exercise oncology is here to stay. I would love to see treadmills and gyms in every oncology center, because when our patients come in, if we start to teach them while they're there, they may be able to keep it a habit for life. And believe it or not, food is medicine. I cringe because I used to take my kids to McDonald's, because I was a busy surgeon and I thought it was okay. And now I won't take my grandkids there when I have them. They're going to eat healthy food. They may hate me and think I'm a ridiculously mean grandmother, but you gotta learn to live. You gotta live your mission. So at the end of the day, all our patients want is peace in their heart. They want to be able to know that they're living their best life, that they can be cancer-free, and that they're doing everything in their power to not get cancer again. And I thank you all, mahalo, so much. This is a rainbow at my house. So I moved to a second place that has beautiful rainbows, because I got rainbows here all the time. Feel free to reach out to me on any kind of social media. LinkedIn is where I'm going to be posting all of the new studies and the things that I'm doing in the survivorship space. And thank you, thank you, thank you.
Thank you so much. For the interest of time, if it's all right, we'll
perfect.
have attendees find you afterwards. Perfect.
I'm sorry.
No, you're so good. Thank you.
A little bit. Yes, I did.
For our next, for our next session.